I am Dr. Suraj, consultant hematologist, MBBS MD DM. I done my DM in clinical hematology and BMT. So good that medico experts is providing an opportunity to put my views in a simplest ways so that it can reach a maximum number of patients and intend to solve a query through these interviews. Thank you. Yes, it's one of the solution and the cancers, the conditions like thalassemia, sickle cell anemia, and the cancers. Because we should know from where all these things arise. These arise from the stem cells, and stem cells give rise to the blood cell precursor that gives rise to the various diseases like diseases of hemoglobin are thalassemia, sickle cell anemia, and the various cancers also arise from such diseases. So when these diseases arise, there is some problem in the stem cells, so that this lineage cause the problems. So most of these conditions can be cured with the effective treatment as a stem cells transplant. So the stem cell transplant is only a curative in maximum number of the hematological conditions. Yes, it's a very good question. Actually, there are various modalities of treatment: chemotherapy, then monoclonal antibodies, related immunotherapies, targeted therapies are also there. Because the medical science in hematology is so advanced, initially we used to kill the cancer cells as well as the normal cells by using chemotherapy. So chemotherapy can cure diseases like Hodgkin lymphoma, but highly effective in some high-grade malignancies, blood cancer malignancies, is not so effective. It just give an option to control the disease, not cure the disease. Then there are monoclonal antibodies that is expressed by the cancer cells, as well as some mutation on which the targeted therapy is implies. But this all treatment then can decrease or retard or control the disease, but can't cure in most of the conditions, because the stem cell from which it is arising, these are still present in the body. Once these treatments effect will wane, that there is always chance that the cancer can come back the more rapidly and more aggressively. So sometimes when we have a fertile ground to destroy the diseased stem cells and to replace with the new energized original stem cells from the donor, then it can cure the disease from the origin of the disease. So that is the motto of the transplants. Essentially, if we see the bone marrow transplant and stem cell transplant is same, only the source of stem cells is different. In bone marrow transplant, we collect stem cell from the hip bones directly with the help of needle. So that is a bone marrow transplant. In stem cell transplant, what we do, we give some injections so that the stem cell come in the circulation, and with the help of apheresis machine, we collect those stem cells. So in the latter state, stem cell transplant, we don't have to take the bone in operation theater from the hip bones, because in BMT, bone marrow transplant, we need to take the patient to the operation theater, and we need to take the stem cell from the hip bones with the help of needles. So stem cell transplant now we do in 98% of the all transplant cases, because easily we can find the stem cells in the circulation with the help of this machine, and we have effective medicines that will make the stem cell to come into circulation. So the essentially bone marrow transplant and stem cell transplant are same, only they differ in the sources of the stem cell from where they are collected. The simplest answer to this is to classify the hematological problems, blood related problems, into the benign category, means non-cancerous category, or cancerous category. Non-cancerous conditions mostly are thalassemia, sickle cell anemia, and aplastic anemia. These are the most common modalities of non-cancerous condition that require transplant. Second modality is cancerous, like we see the leukemias, acute myeloid leukemia or acute lymphocytic leukemia, then lymphomas, Hodgkin, non-Hodgkin lymphoma, and multiple myeloma. So the basic thing is, for non-cancerous condition, if the patient requires really transplant, like thalassemia, all thalassemia doesn't require transplant, only thalassemia major requires transplant, while thalassemia trait or some cases of intermedia can be effectively managed by non-transplant approaches as well as effectively as transplant. Only thalassemia major requires a transplant. So if the patient is eligible in these non-cancerous conditions, we can take the patient directly to the transplant once they have donor and they are eligible for the same. While the cancerous conditions like leukemias, lymphoma, myeloma, we need always to bring disease in the control before moving forward for transplant. Means indirectly what I want to say, in this cancerous condition we need to kill the more than 99% of the cancerous cells and then move towards the transplant, so that it will eliminate total 100% elimination of the cancerous cells are there. So in leukemia, lymphoma, myeloma, we need to wait till their bone marrow becomes clear of the disease, then we can do BMT in such cases. So the summary is, non-cancerous cells we can take directly to the transplant, while cancerous condition requires prior chemotherapy, immunotherapy, targeted therapy followed by transplant. So the sickle cell anemia is also currently means if you see the sickle cell anemia disease, everybody of sickle cell anemia doesn't require transplant, though it's a curative approach in most of the cases. Sometimes there can be minor variation in the sickle cells, when the sickle cell anemia required multiple transfusions, they develop antibodies against the red blood cells. They have multiple episodes of vaso-occlusive crisis. When they have brain stroke, so these are the indication when we require the stem cell transplant in sickle cell anemia patient. Otherwise, patient who can be managed conservatively with the help of medicine, proper water intake, and proper infective measures when they have crisis episodes. So some people can be effectively managed without transplant also, but people should be educated enough to seek medical attention at the right time. So all sickle cell anemia doesn't require transplant. Only the condition what I told, these 4 to 5 conditions are there where sickle cell anemia requires urgent transplant. As I say, is always we divide the hematological problems for non-cancerous and cancerous. So the success rate in non-cancerous condition is always better compared to cancerous conditions. So almost if you see the thalassemia, the chances if we do transplant as early as possible, the chances of cure rate, which with a matching related donor, is almost as high as 85 to 90% if done at an early age, before their spleen and liver gets enlarged in young patients. So it depends on the as early as we do and depending on the donor availability. So in thalassemia it's very high. Same in sickle cell anemia, if required and done at a proper time, it has success rate of 70 to 80%. And aplastic anemia, the same. The thing is, we done at right time, because bone marrow transplant in aplastic anemia is an emergency, because patients don't have their WBC and platelets to fight the infection. So if we do very fast and aggressively, it has cure rate of 70 to 80% in aplastic anemia if donor is available. Then coming to cancerous condition, every cancerous condition requires different type of transplant. Leukemia basically require allogenic, means they want stem cells from other donor. So this malignancy, if we see roughly, the chances of success rate varies from 50 to 17%. in different clinical scenarios and the stage at which we do the transplant. If we see the Western literature, the upper limit of allogenic transplant, they say, is 65 years, while the autologous transplant is 75 years. But as the physical condition of different countries are different, the Japanese are more fitter than the Western populations. Sometimes African community is more fit than Western population like US, UK, and Indian communities are less fitter than all of these. So we can't exactly tell at which age group is a preferable, but usually if we see the allogenic, we keep an upper limit of 65. For autologous, we keep a 75 years. But whenever we assess, we have difficult situation, there is a one beautiful indicator, hematopoietic stem cell transplant comorbidity index. One scoring system is there, where there are various scores given to each our system like cardiac, renal, liver, every other comorbidities has their score. If we calculate the score according to that, then they will tell what is the risk of transplant in such different strata of groups. So currently age is one of the limit, but if the patient performance score is very good, if the patient is like 68 years, but he is very fit, he is an athlete, and he is running 20 years before the comorbidity at the age of 68 years, we can't tell age is only criteria. We have different indicators also. But age is one of the dimension is there in that indicator. A very important aspect of transplant because it involves a risk to life also in some phases of the transplant. So we always need to choose a right candidate for transplant at a right time. So if you understand the basic procedure of transplant is, first we need to collect the stem cells, okay, either from a autologous or allogenic. There are two types of transplant. After this stem cell ensure, then what we do, we destroy the abnormal bone marrow, because our bone marrow lies in the hip bones or some vertebrae. So we have very small space of bone marrow inside our body. So we need to give a chemo or radiation or their combination to destroy these abnormal cells. It provides two things. It will kill the diseased bone marrow, as well as it gives space for normal stem cells to grow there, because the space is limited. Once you make this first step, what we call as conditioning stage, ready, second stage is we need to give the stem cells to a patient. So stem cell giving stem cells is a very simple process. It's just like blood transfusion, just like a blood set. We just infuse the stem cells like our normal platelets or packed red cells, same thing. We give the stem cells. The fantastic character of these stem cells is they found their way to the bone marrow. That is very interesting part. So that we can give as a blood transfusion, we give through the veins and they goes to the bone marrow. They are there and they start proliferating. That is the very interesting phase. So it phase lasts for 14 to 20 days. So conditioning regimen 6 to 8 days. Then after infusion 14 to 20 days to get these stem cells to function. And once they start functioning, then they will give the immunity. They fight with the cancer cells and replace the abnormal cells. So the problem in this transplant process is mostly the time between the infusion of stem cells and their started functioning. In this 14 to 20 days, body is devoid of any immunity, because body is not producing any WBCs, neither they are producing the hemoglobin, neither platelets. So during this, for hemoglobin platelet, we can give platelets and red blood cells, but for WBC we don't have anything major. So we just want this stem cell to act fast. WBC gives immunity to our body. So in these 14 to 20 days body is devoid of immunity, that can cause the complication. So if the patient sailed through this or this is the problematic phase, then the life is very simple for patient as well as a doctor. So this is the most problematic thing. Risk to life is almost 10 to 15% during these phases. It's means if you understand the stem cell transplant is like rebooting your mobile. In when there was no USB connection to transfer the data. If you understand, if you reboot your mobile, your all contacts will go and you have to fade individually. Same with the allogenic stem cell transplant. Once you destroy the stem cells, new stem cell will take time to adjust to the conditions. So that is a problem. So essentially, I divide the transplant complications immediately with the conditioning regimen related, means chemotherapy related. Second, the procedure related complications. So for chemotherapy, as we know, every chemotherapy can cause fever, mouth ulcers, loose motion. Same complication can happen. Then procedure related complication, especially if in allogenic transplant. In allogenic transplant, you use stem cells of different donor, though he is a brother, sometimes a sibling, sister, sometimes, or parents. But whenever they goes to a different body, the stem cell react, as well as the body in which they have infused, they will start reacting. We call this phenomena as graft versus host disease. Graft means stem cells causing reaction to host, means patient. So this is one of the complications that we see is 40 to 50% of cases, but around 60 to 70% it's a mild to moderate, can be controlled effectively in with the help of medicine. But sometimes in 20% patients of all those, they can have a bigger complication like severe diseases. And out of that, 5 to 10% are such patients are there where no medicine will work. That is the most dreaded complications of transplant. So overall, if we see the chances of having the severe graft versus host disease is around 10%, which is not responding to any medicine. But currently there is always a ray of hope. Now, when we started the initial hematology practice, we have come a very long way. We have now very effective medicines are available that can control all the problems, the root cause of problems that gives rise to such a dreaded situations. And the medical knowledge is evolving. We try to understand things better. So currently, initially there was 30% complication with the stem cell transplant. I am talking about allogenic. So, but with the advent of these medicines, the care, the antibiotics, the staff training, we have come to around a 10 to 15% in allogenic transplant. And autologous, if we see, where we infuse the stem cell from a cell body, so the chances of complication comes around 5% in such patients. So we have drastically improved in autologous, and we are keep improving in allogenic so that it will be a very safe procedure.